Hello and welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson, and I'm one of the GP Notebook study group presenters. Now, in this episode, we'll be discussing medication overuse headache. And I'd like to begin with a clinical scenario that may sound familiar. A patient in her early 40s attends a GP surgery with what she describes as worsening migraine. 10 years ago, she experienced 1 or 2 attacks each month, both of which responded well to a triptan. Now, she's having headaches on most days of the week. The triptan doesn't seem to work as reliably as it once did, so she's taking it more often and supplementing it with over-the-counter analgesics. She's convinced her migraine is becoming more severe, and she's hoping to get stronger medication from you. Now, I'm sure this is a scenario most of us have encountered, and our instinct may be to adjust preventive treatment or prescribe a newer acute therapy. But before doing either of those things, it's always worth asking one very simple question. How many days each month are you taking medication for your headaches? That question is often the key to this diagnosis and perhaps the main take-home point of this podcast. So, medication overuse headache, or MOH, is a condition that's common, frequently overlooked, and, importantly, highly treatable. It's one of the few neurological disorders where the treatment itself can gradually become part of the disease process. Medication overuse headache develops in people who already have a primary headache disorder, most typically migraine. Instead of relieving attacks over the long term, the frequent use of acute medication can lead to headaches becoming progressively more frequent, until patients find themselves trapped in a vicious circle of almost daily pain and almost daily medication use. Now, one of the reasons MOH is so easily missed is that the headache itself doesn't necessarily change, so patients will still describe their migraine or tension type headache. But what changes is the frequency. They often tell us that their attacks have slowly become more common over recent months or years. Their medications seem less effective than they once were, and they're relying on treatment earlier and more often. Now, this is a gradual transition, which means both patients and GPs can mistake it for progression of the underlying migraine rather than recognizing medication overuse as the driving factor. Now, fortunately for all of us, the diagnosis itself is relatively straightforward, and we should think of 3 things here. 1. Patients have an established headache disorder. 2. Headaches occur on at least 15 days each month. And 3. Acute headache medication has been overused for more than 3 months. Now, the threshold for overuse depends on the medication involved. Triptans, opioids, and combination analgesics reach the threshold at 10 treatment days per month, while simple analgesics, such as paracetamol and NSAIDs, generally require 15 days each month. Now, these figures are worth remembering because they're lower than many patients expect. And so, someone taking a triptan 2 or 3 times each week may already fulfill the diagnostic criteria. And importantly, it's treatment days that matter here rather than the number of tablets taken. And that's a distinction that's easy to overlook in clinic but can completely change the conversation. Now, although medication overuse headache affects only a small proportion of the general population, it accounts for a substantial number of referrals to headache services, and it's one of the commonest causes of chronic daily headache. So while it may not be something we diagnose every day, it's certainly something we should be thinking about whenever a migraine appears to be worsening. Now, of course, not everyone who frequently takes analgesics develops a medication overuse headache, which does suggest that biological susceptibility plays an important role here. But most patients already have migraine, reinforcing the idea that an underlying predisposition exists. Now, the type of medication also matters. Opioids and combination analgesics carry the greatest risk and are associated with poorer long-term outcomes and higher relapse rates. Triptans can also lead to medication overuse headache, often after surprisingly modest levels of repeated use. And even simple analgesics aren't without risk either, particularly when patients begin combining several different medications throughout the month. Now, although the exact mechanisms continue to be investigated, the current leading explanation here is central sensitization. Repeated exposure to acute headache medication does appear to alter the way the central nervous system processes pain. So rather than recovering fully after each attack, the brain remains in a sensitized state, lowering the threshold for future headaches. And clinically, we see the consequences of that every day. Patients often describe waking with a headache, needing medication earlier in the day, or finding that treatments which previously worked quickly now provide only partial or short-lived relief. So rather than thinking of these patients as becoming resistant to medication, it's probably more accurate to think of the nervous system becoming increasingly efficient at generating pain. From a practical perspective, the diagnosis depends almost entirely on taking a good, careful history. And in my experience, patients rarely come into the surgery saying they may be overusing medication. Instead, they'll tell you that their migraines have become more frequent or that nothing seems to work anymore. And that's why the medication history is every bit as important as the headache history. So ask specifically how many days each month medication is used. Ask about over-the-counter products, combination analgesics, and medications taken for other painful conditions, because patients don't always consider those relevant to their headaches. A patient with migraine taking daily analgesia for chronic back pain may still develop medication overuse headache, even if the medication wasn't intended for migraine in the first place. Now, I do think that headache diaries are particularly valuable here, because patients often underestimate both headache frequency and medication use until they see it recorded over several weeks. Physical examination is usually entirely normal, and unless there are red flags suggesting an alternative diagnosis, imaging is generally unnecessary. So this is very much a clinical diagnosis made through careful listening rather than extensive and usually unnecessary tests. Once a diagnosis has been made, management focuses on breaking the painkiller cycle. And this is often the point where consultations can become more challenging. Patients have usually developed understandable confidence in the medications they've been taking. After all, those medications worked so well initially, and suggesting that they reduce or stop them can feel counterintuitive. Education is therefore the foundation of successful treatment here. Patients need to understand that medication overuse headache is potentially reversible and that temporary worsening during their withdrawal is both common and expected. So preparing patients for that possibility makes it far more likely they'll persevere. So the current practice is generally to stop or substantially reduce the overused medication while introducing or optimizing preventive therapy. And any preventive treatment should be individualized according to the patient's migraine history, previous treatment response, and comorbidities. Traditional therapies remain highly effective for many patients, while newer options continue to expand our ability to manage chronic migraine successfully. Patients overusing opioids or combination analgesics may require a more gradual withdrawal strategy, and some will benefit from additional support during this period. But the goal, however, remains consistent: to reduce dependence on acute medication while improving long-term headache control. And it's also worth remembering that medication overuse headache rarely exists in isolation. Anxiety, depression, poor sleep, chronic musculoskeletal pain, and lifestyle factors all commonly coexist and may all influence recovery. So addressing these issues alongside headache management usually produces better long-term outcomes than focusing on medication withdrawal alone. Follow-up is equally important. Recovery doesn't end just once the medication has been stopped. Early review allows us to reinforce education, adjust preventive treatment, monitor withdrawal symptoms, and help our patients avoid slipping back into previous patterns of medication use. Now, the encouraging news here is that most patients do improve. Successful withdrawal is associated with meaningful reductions in headache frequency, improved quality of life, and restoration of responsiveness to acute migraine treatments. But relapse isn't uncommon, particularly when preventive therapy is ineffective or contributing psychological and lifestyle factors remain unaddressed. So just finishing here, I'd remind us all of what I think are the three key practical messages here when considering medication overuse headache. First, whenever migraine appears to be getting worse in a patient, consider medication overuse before just assuming the disease itself has progressed. Second, remember that one vital question: how many days each month do you take medication for your headache? This can completely change your diagnosis. And finally, MOH is one of the most rewarding headache disorders to treat because recognizing it early can dramatically improve a patient's quality of life without necessarily prescribing anything new. So that's an overview of medication overuse headache, and I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favorite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.